morning, everyone. Very nice to see so many people here in real life, and I know that we also have a virtual audience. So welcome all to this session focusing on risk reduction and risk reduction and prevention, the latest in research and the challenge of bringing new message to the broader audience. My name is Miia Kivipelto. I'm professor in clinical geriatrics at Karolinska Institute. I work also part-time here in London, Imperial College London. And it's my great pleasure to moderate this session. I want to thank ADI for the invitation and also putting focus on risk reduction. We all know that it's a very important area, and actually prevention and risk reduction have been highlighted as the key elements if we want to manage the global dementia epidemic. I would also say that during the pandemic, this area is even more important because we know that the pandemic has been affecting the brain health in a negative way. It has been affecting many of the risk factors in a negative way. And there have been a lot of developments in the area of risk reduction. And I'm so happy that we have here the world-leading experts who will discuss these topics. What has happened in the prevention field? What are the gaps in the knowledge? What type of studies we need to do? We have both the observational studies and intervention studies. And one important question is also the implementation. How can we start using the results from our studies? What is needed? What kind of collaboration? What is needed on individual level and on societal level? Is it the policy change? What is needed from the policy makers and so on? So this will be, I would say, the big part of the discussion we will have today. And one more focus area is really the global picture. We know that the numbers are increasing even more rapidly in low and middle income countries. So if we are thinking prevention, we need to find global solutions. So we'll really focus a lot also on low middle income countries, not only finding effective ways to prevent, but also feasible and scalable ways for that. So I'm really looking forward for an interactive discussion. We will do like this. The panel members will first give a short overview or remarks, like opening remarks, highlighting just a few areas from their perspective. And then we will have a discussion, I hope very interactive discussion, and of course a lot of questions from you. So that's the goal of the meeting we have now. With these words and without further delay, we move on to the panel overviews. And the first speaker is Professor Giovanni Frisoni, who is the head of the clinical neuroscience at the University of Geneva, and he's also running the memory clinic. So Giovanni, I would guess that you will give a bit memory clinic focused, brain health clinics, biomarkers. Please, the floor is yours.
Thank you, Miia. Dear colleagues, ladies and gentlemen. Yes, I'm a neurologist. I work in a memory clinic. So we see patients coming with memory complaints all the time. And some of them, they do pretty well on memory tests. So their complaints and concerns are not mirrored by any cognitive impairment. So they're basically healthy, okay? Technically, they're not patients. Well, these people, why are they coming to us? Well, because they feel that their memory is not working as it should. The way it should is a matter of subjective judgment, of course. But or because they're worried because their mother, their father, they had dementia, they had Alzheimer's, and they come to observation. So we reassure them, we tell them, you're fine, don't worry, be happy. But that's not enough. The question is, what should I do to prevent to prevent Alzheimer's in the future? Okay, I'm happy I don't have it now, but I would like not to have it tomorrow as well. So what do we say? Well, make physical activity, eat well, Mediterranean diet, be active mentally, avoid toxic substances, alcohol and more toxic ones, treat cardiovascular risk factors, and that's it. Well, you don't really need to go to an academic memory clinic to hear those recommendations, right? You open any magazine and you find the same things. And they're useful for the brain, but they're useful in general. They're protective in general. So where does the future lie? Well, I believe that the future lies here. I'm slightly embarrassed to speak about risk factor with Gill Livingston in the audience, but okay. This is a study that's come out recently. Well, it's not yet come out. It's it's a preprint where they have studied 1,300. Okay, it's not working. 1,300 persons, healthy persons, it's like those who come into our observation with no cognitive impairment. Okay, it might be me, it might be you, it might be my patients, these persons without cognitive impairment, and they studied amyloidosis and tauopathy, the deposition of amyloid and tau in the brain. I'm sure that everyone knows what these are. And what do they find? Well, they find that they divided all persons into 4 groups. Those with neither amyloid nor tau. Those with amyloid but not tau. Those with tau only in the medial temporal lobe, the hippocampus. And those with amyloid and tau in the neocortex. Not only in the hippocampus, but also in the neocortex. So widespread tauopathy. And what they find is that those with so-called A+, D+, amyloidosis and tauopathy, they have a much, much higher risk of developing dementia in the following few years. Now, they followed for 6 years, but let's stop to 4 years, because after 4 years, the number becomes, there's just a few patients, few observations. So even if you cut the observation to 4 years, the risk of A+, D+ is very high. It's not certainty, okay? Because after 4 years, only 25% of A+, D+ in the neocortex have developed dementia, which is a lot compared to the others, where the most you have is 10%. So the relative risk is huge, but still, 75% will never develop dementia. So, there are 2 facets. 75% do not develop dementia after 4 years, but the relative risk is huge, or vice versa, depending on how you say things. So the risk factors, the modifiable risk factors that have been described by in the literature and that have been summarized so well by the Lancet Commission led by Gill Livingston, they should be integrated with something more. Here you have the risk factor, the lifestyle modifiable risk factors, with the relative risk that's reported by the Lancet Commission. And here you have the genetic risk factor, which is something more, ApoE4, 1 copy of the E4 allele of ApoE, 2 copies of the E4 allele of ApoE, amyloidosis alone, amyloidosis and tauopathy, neurodegeneration, amyloidosis and neurodegeneration. We do not have all the possible combinations because the studies are limited. Well, subcortical cerebrovascular disease as well. And as you can see, the risk associated with the biological and genetic risk factor is way, way higher than that associated with the lifestyle risk factors. Now, there's a number of methodological issues here, okay? I'm aware of that. In these studies, the biological risk factors were not studied. In these studies, the lifestyle risk factors were not studied. So the comorbidity of risk factors is something that's not been taken into account. But I believe that the picture is quite eloquent, that once we have drugs to treat amyloidosis and tauopathy, that will be a way, certainly a way to go to prevent dementia. We will never forget, of course, the lifestyle risk factors should not be forgotten, as it is the case of the prevention of vascular diseases. You treat all risk factors that you have. If you have more risk factors, you treat them all. But the biological ones will need to be put into the picture. This was the message that I wanted to deliver. Thank you.
Thank you so much, Giovanni, for this very nice overview. And the next speaker, Sandrine Andrieu, Professor of Public Health at Toulouse University Hospital. She's also the chair of the clinical epidemiology, and we have had the pleasure to work together with many multi-domain interventions, so I guess you will show us some experiences from the trials and the next directions. Please, Sandrine.
Thank you, Miia, and thank you, the ADI, for organizing this exciting session. So I will show you some results about intervention trial, because usually when we analyze all the intervention trial, we are very disappointed, because most of the trials that were published so far were negative. Of course, we have few that were positive, one with the antihypertensive drug, and one, the one of Miia, the finger trial on multi-domain intervention. But the question is, why so many trials failed? And in contrary, in epidemiological study, we have so many positive, so many factors that have demonstrate the same size that Giovanni showed you. So maybe the point that I want to underline today is the participants who take part of the preventive trial. So we want to have enough subjects, because, of course, many of them will never develop the decline. So we need a lot of subjects. We need subjects who are healthy. We not need persons who have already the disease, but we don't need persons too healthy. And that's a balance that we need to take into account. And just to underline the selection bias that we analyze in many of the prevention trials, and let's take, for example, the level of education of the subject. In our country, the level of education of elderly subjects is 12% of the elderly population who have got a high diploma degree. But once you are looking the person included in preventive trial, you raise this percentage to 25% if you have a simple preventive trial. And if you go to a multi-domain intervention trial, which is very demanding for the people, you raise to 45%. So, of course, the population that you enter in your study is not the population that you want to address specifically. And when you are doing prevention on dementia is really a point, because if you include only subjects with a very high level of education, for sure, with the cognitive reserve, this person will never develop the disease, or they develop the disease, but if you miss the window when the cognitive decline appears in this particular population, if you miss that with the trial, you miss the ability to detect the effect of the intervention. So that's an issue for us. So we have done a large multi-domain intervention and focusing on physical activity, cognitive stimulation, diet advice. And we say, why we missed the point? Why this preventive trial was negative? So we reanalyze the data. Of course, it's still negative. It's not the way to say that it's positive. But when we analyzed a subgroup of subjects at risk to develop the dementia. So the people who were included in the finger trial and the people who have positive PET scan with the AV45 in the brain, the mapped trial become positive. So in fact, if you really focus on the population that really need intervention, maybe the way to have positive results. So we asked the people, why did you don't want to take part to our study? And of course everybody say, I'm too busy. I'm too busy to take part to the study. But when the sociologists and psychologists analyze deeper the question and go to an interview to ask the people, why did you refuse to take part? It's because they did not believe that our intervention will give benefit for them. Because in the media, there is a representation of the disease that is terrible, and they think that there is nothing to do with this disease, and so they refuse to take part. Maybe one of the messages is that we need to change also, and we repeat that maybe since 30 years, we need to change the message about the disease in order to bring the people in this part, in this trial. So after that, we need to follow them for a long time, sufficient to see an effect, but not too much, not too long, because after that, they have a decreased level of the adherence of the intervention, and that is a key that we can discuss after that. So how can, finally, we can find the same results with a trial if we want to replicate what was observed in observational study? Because when we are doing a trial, we are focusing at the very late stage of our life and with a very narrow window of exposure. So if you miss the point, you miss the probability to see an effect. So why we need trial? We need trial because in terms of level of evidence, the RCT are the more convenient, are the more they give you the confidence of the results, but only if you have some quality for this randomized control trial. And for sure, when we are doing lifestyle intervention, we are miss most of these points. Example, the double blind of the intervention. Example, the subject that need to be the real subject that you want to address. So if you meet the quality of the randomized control trial, you miss the point that you need the randomized control trial. So to conclude, I will say that there is an imbalance between observational study, which is a real life, and interventional study, which is an experimentation. So we need to decrease the gap between the two. And on the top of that, when we are talking about prevention, we are thinking to have a result at a populational level and not at the individual level. And the RCT give you results at the individual level. So as we are in UK, I would say to do or not to do preventive trial, and I will let the floor to the other speaker to maybe have an answer to that. Thank you.
Thank you so much, Sandrine, for highlighting this important point, why it has been so difficult to translate the epidemiological and experimental findings to successful trials. And this is not only lifestyle, it's also happening in the drug trials. So that's a challenge in a way in our field, and happy to come back to these issues. And the next speaker, Gill Livingston, Professor of Psychiatry of Older People and Consultant Psychiatry, University College London, and we already heard, Gill, about your wonderful Lancet Commission paper. That is the figure I think is so much cited and used and has been really opening the view. What is the prevention potential? And what you also nicely wrote, we should be ambitious about the prevention. I like that a lot. So, Gill, what are your points and opening remarks on this issue?
Here it is. Here it is. Okay, thank you very much, Miia. So it looks like all of us are interested in the same thing, although we didn't really talk before about what we were going to say. So I'm going to talk about targeting and personalizing interventions, because as with the other speakers, I think that if we try and prevent dementia in people who aren't going to get it, then that's not really going to be a useful way of using our resources and helping people, which is most important. So I put this up because Miia told me to. I came without any slides, and then everybody else had one, so I've very rapidly put this on, so this is the slide that Miia says that I should show, and I think most of you will have seen it. And what it shows is that through the life course, 12 risk factors account for a possible 40% of Alzheimer's disease and other dementias, and that is taking into account that human beings don't just have one thing, they don't just have the gene, they don't just have hypertension, they have clusters of risk factors together. So we're taking that into account. But is the risk the same for everyone? Well, it's not. We used worldwide figures, and by worldwide figures, that means we used all the good studies in the world, and it happens to be that over 80% of them are in high-income countries, although over 60% of people with dementia live in low-income countries. And not only that, but they tend to have in it people who volunteer for studies, very much more than those who don't, and they tend to be predominantly white, and they overrepresent higher socioeconomic classes. And so our figures are worldwide, not individual countries, and even worldwide, through no fault of ours, but just because that's what literature is always like, they overrepresent the richer countries. So after the first Lancet Commission, when we were only talking about 9 risk factors, we tried to do the same analysis in other countries, in low-income countries, and doing a very similar analysis to that which we had done before. So with the 9 risk factors, we found 33% risk worldwide. We found much higher risk. And in Latin America, we added together lots of Latin American countries because all the numbers in them were very similar. The number was 56%, so a 23% increase of potentially modifiable dementia, thinking about the same risk factors, and that is because people have different patterns of life and different risks. For example, they have it's much more common not to have education in these countries. So it varies between individual countries, and even within individual countries, it varies. So this was an analysis that we published with our colleagues in New Zealand, looking at New Zealand, and nobody is going to be surprised, but we didn't know it before, to find that the Maori and Pacific people are at much higher risk than East Asians and white Europeans. So again, risk factors, you have to think about individual countries, and you have to think about individual cultures and how and what happens within them. So many people, there's been a very welcome reduction in many high-income countries in the incidence of dementia, and that has been about 25% over the last 20 years. But that is restricted to people in higher income brackets with more education. So even in high income countries, there's a massive number of people who are untouched by the reductions in dementia incidence. And culture, poverty and inequality drive both dementia and the need for interventions. But as has already been pointed out, it tends to be the very people who need it most, who are not in the intervention studies or have very little changes in lifestyle, are still living in poverty in today's high-income countries with less education. And therefore, we need to target and help people to get in. And as you said, to believe that this may help, we need and change what is happening. Otherwise, we're not going to make the changes. So my last point before we go is that the brain is very important, but the real massive change in public health has been in cardiovascular disease, which hugely dropped. And if we just studied the heart, we would probably still now be looking for drugs to reduce thickening of heart muscle. But the difference the huge difference in cardiovascular morbidity and mortality has been driven by changing the risk factors from epidemiological studies. And I think we must keep this in mind when we think about dementia. It's no competition between lifestyle and drugs. But when we look before at what's been useful in other contexts, we should really learn something about dementia. Thank you for your attention.
Thank you so much, Gill, and this is a very good conclusion already now. We should learn from other disciplines, and it's the combination, is the lifestyle and drugs when needed, and the tailoring of the intervention. So I think this is a very, very important point. Next speaker is Kate Swaffer from Australia. Very happy to have you here. She's the researcher and honorary associate and has been really the champion for the human rights, dementia, rehabilitation, all these issues. So please, Kate, happy to hear your points.
Thank you so much, Miia, and fabulous presentations from our other speakers. I'm feeling a little bit intimidated by them. I don't have any slides. I felt with 5 minutes to speak, slides probably weren't necessary. And I thought I'd start really with a consumer or a person with dementia and a family of person with dementia perspective. So a number of years ago, I did a tour of speeches for the Primary Health Network annual conference in Australia, and I delivered a presentation on all the current risk reduction guidelines at that time, and not long after that the WHO risk reduction guidelines came out. And at every single conference that I went to, whether I was in Sydney or Adelaide or Perth, a lot of the family doctors, general practitioners we call them in Australia, said, look, I understand the science of risk reduction, particularly lifestyle factors, and they're very aligned to reducing heart disease, cardiovascular disease, diabetes, and so on. But they all said to me, the problem is we can't get our patients who are at risk of diabetes or heart disease to engage in lifestyle changes. So I think we've got that same problem with dementia risk reduction. It's actually engaging people to do the simple things like give up smoking, give up high levels of drug use, including alcohol, and to get fit and lose weight. That is an issue, I think, for patient community and the medical community. 10 years ago, the ADI conference, I gave a number of presentations. It was my first year attending a conference, and I presented on my own non-pharmacological interventions for living more positively with dementia, and it was not very well received by the scientific audience at that time. The next year in Taiwan, a Chinese doctor gave almost the same presentation that I'd given the year before, because of course people in Asia have been using Eastern medicine and holistic health for thousands of years. So we all know that there are at least 55 million people with a diagnosis of dementia. There's a new diagnosis somewhere in the world every 3 seconds. There's ADI reported 42 million people without a diagnosis, but I would say there are many more than that. But whether you're trying to get a diagnosis or whether you're trying to get care and support after a diagnosis, it very much depends on which country you live in, and in developed countries, which postcode you live in and your socio-economic status. Because in Australia, I asked my neurophysiotherapist, who's a stroke specialist, to pretend I didn't have young onset dementia and treat me as if I had stroke. Because I know if I had a stroke age 49, I would have been given a full suite of rehab. Instead, with dementia, I was told to go home and die. And so he did that, and he now calls me his case study of one, and he's a lecturer at Flinders University, runs a Masters of Neurophysiotherapy course and includes rehabilitation for dementia. So dementia doesn't discriminate: age, sex, education, socio-economic status or country. And I think an approach to risk reduction to prevent dementia is equally as important as potential drug interventions. And I think it's very important as an approach for people once they're diagnosed with dementia, because if you're diagnosed with diabetes, you are told to engage in a whole load of risk reduction or living better life with diabetes, for example. And I know that my self-prescribed, if I look in the risk reduction guidelines put out by the WHO, I've been living that lifestyle, changing my lifestyle ever since I was diagnosed, and it has slowed the impact of the progression of my dementia. It hasn't cured it, but it has slowed it. And I think I wanted to bring up a point, I've forgotten your name, but one of the other speakers spoke about the messaging of dementia and how difficult it is to get people into prevention trials. And I think that the persistent messaging of suffering and death and the therapeutic nihilism attached to dementia is a major problem, and people with dementia have been asking for the global community, including the media, to stop using the language of suffering and to only focus on the tragedy of dementia. But the problem when those of us who dare to live more positively and live public lives positively with dementia, we then have the cohort of specialists and scientists who then believe we don't have dementia. So there's a real kind of risk. You live well with dementia, therefore you can't possibly have it. But to keep the messaging of suffering means that really important drug trials and non-pharmacological interventions and risk reduction trials are being delayed. So I think it's really important that studies, I think from my perspective, I would like to see some studies on the economic potential of reducing the economic cost and human cost of dementia through preventative lifestyle factors, and that may or may not have an economic impact, but it certainly will improve the lives of people with dementia generally. If you get fitter and you eat better food and you exercise more, you feel better. But I think the other thing, that there is novel research around the world, scientists like Professor Dale Bredesen, who are reversing or slowing down mild cognitive impairment and early stage Alzheimer's disease. And he and a growing number of other researchers are moving into a non-pharmaceutical approach to reversing or slowing down dementia. And I personally would like to see a lot more focus on that in the scientific community. So thank you very much.
Thank you so much, Katie, for highlighting these important points, and also the health economic aspects I think should be highlighted. We have been actually now analyzing the finger data with Anders Wimo, and we could show that there are health economic benefits, not only neutral, it's cost saving. So this type of analysis, I think we should see much more. Thank you. And finally, Gustavo Sevlever from Fleni Institute, Argentina. I know you have been involved in many global initiatives and now more and more in the prevention field as well. So please, Gustavo.
Okay, thank you, Miia. I want to thank the organizers for the invitation, and I want to share with you our experience with implementation, the early steps of implementation of the Latin finger experience in Latin America. Well, you all know the landmark paper about the risk factor, but I want to stress that in Latin America as a whole, perhaps 56% of the factors can be are doable for an intervention. And we all know that in low and middle income countries, the thing is much worse concerning dementia rates. So that was more or less the essential element for setting up the Latin finger, the experience of fingers in Latin America. This has been a tremendous challenge, and I want to share with you some of the things because I think they are important, at least in our experience. Latin America is not an homogeneous region. It's a highly heterogeneous region in whatever aspect you want to look at: genetic, economic, health system. For example, in Argentina, health systems are extremely heterogeneous, from the national health system to local health system, and even the unions that have more or less half of the health system of the country. So it's very difficult to implement national policies of whatsoever, not only dementia, but cancer and infectious diseases. So that is a huge challenge. And one of the most important things we have been able, through Fingers, through Latin Fingers, to put together a lot of people, physicians, trained physical trainers, nutritionists, neuropsychologists, in the whole region. We are 12 countries working together with the same protocol, with the same teaching tools, with the same objectives, and this has never been done, as far as I know, in anything, not in neurology, not in dementia, not in medicine itself. So it has been a huge step for the region to put together a protocol and to gather a lot of people working in the same protocol with the same objectives. This is the Latin Fingers, Latin American Initiative for Lifestyle Intervention to Prevent Cognitive Decline and Reduce Risk study. And one thing was very important, to make the educational tools for the treating team. And because, as I said, there's a heterogeneous group, physician, a lot of people working together, and we use the digital tools in all the regions. And this is Manito. Manito is a bot. It's a chat bot that we make. Manito is kindly work in Spanish and Mexican, making friends, something that have to be like brother, hermanito. And the Manito is a chat bot that we have been using in all the region for questions related to the protocol itself and its implementation. These are the randomized participant, the results. I have the new data from yesterday. We have more than 700 people randomized and more than 300 people in the intervention. And the demographic data, and this is a point that perhaps we can discuss a little bit, we have a huge predominance of female people involved in the trial, a huge predominance. And if we look at the census, the population census of Latin America, this is not a representation of the real population data. So we have this representation, a high representation of the female people or subjects in this prevention trial. We discussed this in Cartagena in a recent meeting of all people involved in the trial, and there were some people that want to make special intervention trying to equilibrate both aspects, and the decision was not to do that because this is a feasibility study, so this is what it is, this is what we are getting. Later on, when we have the final data, perhaps we can implement other policy, but this is the real world, this is the response of the people of the society to this clinical trial. And this is all over Latin America, not only in one or two countries. So I think this is an important point. And this, to end this is an editorial of a Lancet Neurology at the end of 2020, stressing the importance of this trial for the region. So and now we are really happy to be working in that, have been extremely useful for the region and for the medical and non-medical team related to it. This is funded by the Alzheimer's Association of the US, and we need to thank them for the support, and we need to thank Miia and her team for the scientific support all the day, all the time, for making the final arrangements to the protocol. So this is our experience, and we are extremely excited on that, and we hope that in another meeting we can get more results of the real data of this intervention. Thank you so much.
Thank you so much, Gustavo. Very impressive to put together the whole Latin American region, and after the pandemic that you have been able to do these steps. Also what you highlighted, who is the target population who are coming to the trials, is an important thing, so really something to discuss more. I know there are surely many questions, but I have a very short follow-up question for each of the speakers, just to put together a little bit of this fantastic talk. So Giovanni, you are working at the memory clinic, and one question what often is what you also mentioned, what can we offer to our patients, and do you think you have time at your memory clinic setting to provide this lifestyle intervention for your patients, you have been also highlighting the brain health clinic concept. Do you think that's the future?
Yes, well, thank you, Miia. The memory clinics that we have, the way they're run today, they're not designed to address the needs of persons who want to do prevention. The memory clinics that we have today, they're designed to address the needs of persons who have disease, who have already dementia or at least MCI due to Alzheimer's, who have cognitive impairment. Because in those settings, we do diagnosis, treatment, rehabilitation, but we do not do prevention of those without cognitive impairment. In order that population needs something different. That population needs risk assessment, which is different from diagnosis. They need to be explained what risk is, and here we come to communication. Telling someone you have disease X is relatively easy because either you have it or you don't have it. It's like being pregnant. You cannot be half pregnant. But for risk factor, for a risk, you can have low risk, intermediate risk, high risk. So the communication aspect is much more complicated. And then you have to implement risk reduction, intervention. Then we have no protocols in memory clinics. So we have to develop a new concept of the memory clinic, what we've called the brain health services. And actually, I would like to spend, in the US mainly, there's a number of market initiatives which are called brain health services. I heard the Bredessen's protocol had been mentioned. The Bredessen's protocol has no evidence at all. So let's not mix things. Miia has done a clinical trial spending a lot of money with many people involved, a lot of energy, very strictly, very accurately designed, great science. That's the way to go, not magic, not initiatives which are purely market, purely money-making. So what we're developing with Miia is the concept of the memory clinic of the future, which is the memory clinic where we will do risk assessment, risk communication, risk reduction, possibly cognitive enhancement, which will be different from the current memory clinics.
Thank you so much. And highlighting important point, the evidence-based, scientific base, when this is an important issue, so we need to be careful where is the knowledge. Thank you, Giovanni. Sandrine, you mentioned about the challenges in the trials, which we all know, and I'm thinking the future possibilities. Can we use more new technology to advance in the interventions, both to measure and make the intervention, remind people to follow the healthy lifestyle? What is your experience about using new technology in the next generation of clinical trials?
Yeah, so we have some experience with the European preventive trial like ATIS, where we use a website, and like ProDemos now, where we use a cell phone. It's running by Edo Richard. And in fact, of course, it can help. But on the other side, it can increase the selection bias of the population, because the person who are now ready to enter in that study, they are not used during their professional life to use internet, and they are not very friendly with that. So sometimes they just refuse to take part because they are not familiar with this technology. Yeah. So I think it will be changing very rapidly, where everybody now is using more and more. And except for that, I think it will be something very useful, because it decreases the burden of the trial. It decreases the fact that we need to come once a month or two times a week, it depends. So it can decrease a lot the burden of the trial. So my response is mixed, in fact. Yeah. Maybe better in the future, but now we still have this selection bias.
Yeah. And that's the thing, how we are planning the future trials. So we are learning a lot of that as well. Perfect. Gill, one question, the prevention potential, that's always the question, how much we can prevent dementia? Is it this 40%? And you have been now adding these new risk factors like hearing loss, air pollution. What is your feeling for the future? Will the prevention potential be even bigger when we can find new risk factors, and especially these newer risk factors like hearing loss and air pollution? Could you say a few words about that?
I'm sure there are more risk factors. Excuse me. We took a very high threshold, and there had to be consistent, high-quality evidence of risk before, which was biologically plausible before we put it in. So I'm sure there are more. There's more evidence about vision loss. There's evidence about things which won't be very high in a population level, but about psychosis. We don't have food in, though nearly everybody thinks it should be because of the inconsistency of food and the difficult. We recommend people to eat well because it certainly might help. That's what the WHO says, and it won't do any harm not to take vitamins. It's a bit like it's yet another racket, could I say? It doesn't. These things don't work. So, but I think probably there is something in food, but food is so complicated and so lifelong. It's very, very difficult. We don't have food. We don't have sleep. I'm sure that there are more risk factors. So while we find more, but we've also got to help people change behaviour, think it applies to them, and target the people who really are at high risk. And these are the things that are really going to make a difference.
Perfect. Yeah, very, very exciting to think that we are also changing. It's not only individual risk factors, it's the environment where we are living and how easy it's also to do the lifestyle changes. It's different for different people.
Absolutely, and we can't change air pollution.
No.
So many, many things have to be changed at a policy level.
Yeah.
It has to be safe to walk the streets or nobody's going to do it. It has to be easy to get healthy food or people get obese. There has to be, policy is extremely important, and it's much easier to change people through policy than to get every individual to decide to change themselves.
Good, thanks. Kate, how about, you mentioned the WHO risk reduction guidelines, which I think is an important document, really giving the evidence base and supporting implementation. What's your feeling? That was 2019, now it's 22. How far have things started to happen in the implementation? What are the main barriers?
I'm not sure they have started to be implemented, and I think that we need to engage with primary healthcare networks around the world. They talk to patients about all of the other chronic health condition risk factors, just add in dementia to that. But I would also like to respond to the comment about Bredesen and his less than scientific approach to dementia. We had the release of Andrieu recently, and there's been a huge fuss around the world that the CMS and others have rejected this drug. And some patients have been upset about the fact that their right to have a choice about that drug has been denied unless they're in a clinical trial. There are many, many people with dementia who have found Bredesen or other lifestyle approach scientists and healthcare professionals' approaches to living with dementia the only ray of hope they've had in decades. Has been unsuccessful drug trials for years and years and years and years. We don't have no disease-modifying drugs. We are not really anywhere near a cure for dementia. We're not near eradicating cancer either, and cancer gets a lot more money in research than dementia does globally. So I think it's wrong to patients with dementia to just absolutely ban an alternative approach.
And you are highlighting important point, how to also communicate the results from the trials and implement that. What parts of the lifestyle interventions are more evidence-based and not, and how much evidence is needed for some of the implementation. Here I really feel that the communication, what is the next step for the implementation, is really, really important. That's where the field is now. So that's also maybe we should work more about the messaging.
Yeah,
and
it'd be good to see that in undergraduate medical training as well. I think that would be really helpful, and nursing.
Yeah, very good. Finally, Gustavo, lat and fingers. We are always thinking that you should not only copy-paste the trial, but really adapt it to the culture. That's important that the community support is there. Otherwise, it will not be sustainable. What are your main learnings so far in Latin American settings for the 5 fingers and risk factors? What are the main adaptations or challenges needed to make it really successful?
I think that food is the most important thing. To have a Mediterranean diet in Mexico, for example, is a huge challenge, really a huge challenge. So we have been working with nutritionists all over the region, trying to adapt the food diet to the local custom. And this has been, I think the main challenge is that. Physical exercise is not so complex, but we have to be training people, train the trainers, because the trial is challenging in terms of physical activity. So we have to develop the trainers and to train the trainers. And this has been done all over the region. So I think that these are the 2 most important things. Food perhaps is the most difficult to set up in the whole country.
Yeah.
And there are other things related to language. For example, in Peru, some people from Indian origin, native people that speak other languages, and other Aymara, for example, is a completely strange language for our standards, and so they speak completely different. So the evaluation of the language in native people is extremely challenging. And the people in Peru are doing an extraordinary job in trying to adapt the common test to the local needs. So I think these are the most important challenge in the region.
Thank you. And I fully agree. Diet is, of course, so different. And still, what are the healthy dietary patterns? Nordic diet, Mediterranean diet. We should also not only, again, copy-paste, but find the local kind of healthy food for the brain. So I think that's so important. Also, the harmonization, what you mentioned. We have a unique opportunity for the prospective harmonization in the worldwide fingers so that it's easier to compare the results. At the same time, we need to find the tests which are feasible for that population. So I think that's a both challenge and great opportunity.
Yes, we were discussing about the digital tools and the digital culture. One unexpected effect of the pandemic was that the old people learn very quickly to use the cell phones and the tablets because they need that, because for example, Argentina was one of the longest lockdown in the whole world. So for example, a grandfather, the only way to see the kids was to use the tablet and the phone. So there have been a crash course in digital culture.
Yeah. Yeah, it has been speeding up. Yes, the pandemic has been speeding really up that development. So that's true. Wonderful. I'm sure there are a lot of questions from the audience or comments from here. So please, maybe Francesca, I don't know, can you help me to capture it, or is it Katie there? Oh, there. Yes, good. And please, if you can give your name and institute where you come from, that would be great as well.
Thank you. Thank you to the fantastic panel. Dr. Catherine Charlwood, University of Exeter. I'm really interested in the messaging that you were talking about, and as Kate was saying, this sort of tightrope between positive and negative messaging. And of course, it depends on the audience you're trying to speak to, because I can understand perhaps the need for negative messaging if you're trying to convince governments to do something about what they need to see as a problem, or perhaps if you're trying to convince people to donate, et cetera, et cetera. However, we need to make much more room for this positive messaging. So my question is, therefore, in risk reduction research for dementia, is there room for perhaps further collaboration with perhaps behavioural psychologists, or dare I even say it, medical humanists, to understand which things motivate people or not to participate in these trials? Thank you.
Thank you. That's a great question. Who from the panel wants to start? Jill?
I just wanted to mention that NHS England has started to offer risk reduction in dementia advice for people when they have their NHS check. Unfortunately, during the worst of the pandemic, there was no NHS check. But taking that aside, and they say to people, would you... you must live a healthy lifestyle, say that to everyone. But actually, for you specifically, this is likely to reduce your risk of dementia. And they did a pilot at the beginning and said that it made much more difference in people changing their behaviour, because people do not want to develop dementia. They're frightened that they will lose their personality, their independence, their past. And so I think that people are beginning to think about it. And in America, the CDC has now decided to do a massive risk reduction program tackling risk, and they've got outcomes and numbers of reduction in risk that they are going to do over the next 10, 20 and 30 years. So with a reduction in each of the risk factors during the time. And I think that's what we need. Obviously, we do need to think about how individuals can be motivated to change within trials, but we really need the big changes from government to decide that this is very, very important to target and make a difference to these risk factors.
Perfect, thanks.
Yeah,
okay.
I'll add to that. When I was talking about that with Primary Healthcare Network General Practitioners in Australia, the GP said to me, so how do we get patients to get engaged in prevention of heart disease or dementia? And I said, well, maybe this is the time, the only time, you use the fear of dementia, and dementia is the most feared disease now, I think in above 40 age in the UK, certainly in Australia, over 65, it's the most feared disease. So maybe that's the time you use the negative messaging when you're at the GPs and you're at a high risk of dementia, but we need the more positive messaging out in the community.
Or the positive message that there's something you can do, because that's what you're saying. People don't believe. The positive message is things have really changed, and you can make yourself much less likely to get it.
Yeah. Perfect.
Yeah, in Argentina, there's a lot of people living in cities, not in the rural area, but in cities. So we have been in contact with the health officers of the city, not the national level. And health officers of the city are much more related to for example, in Buenos Aires, 25% of the population is over 65. So it's a problem, and they realize it's a problem. COVID make displacement all of the priority, but now they are going back. So with the city officers and with the lay press, we have been a very fruitful association in terms of developing the message.
Very good, very good. We have been also working with the PPI activities, patient-public involvement. I think it's important also that we involve patients, what language to use, how to communicate. So absolutely area where we should put more focus on. Giving the time, I would love to get some more questions from the audience if there are. There is one, if we get the microphone here. Yeah, it's coming there.
So my question relates in part to what Giovanni was saying, let's say about like the Bredesen. I understand that that's been a critical part of much medical scientific research, but I also see, I think, some shifts in that medical scientific research has got very, very set parameters, and it often like it's looking at maybe a cell or something like that. But when we're looking at a whole person, and dementia really is like the whole person, and it is a lifestyle thing, I'm just how much is the medical scientific community looking at alternative ways of treating something at a more holistic level. I think there's some evidence starts to that. But I'm just interested in how much that's on the table.
Yes, well, thank you for the question. I believe that what good clinicians do and should do in dementia care is to consider the patient in his psycho-social, biological dimensions. The patient is not only biology, it's not only psychology, it's not only relationship, it's the whole thing. So I believe that this is what we do in the clinic. We take into account all the different facets. Now, what the Bredesen protocol is something that always excites. I believe that what we must work with, what we should offer our patients is evidence, is something that we are confident that it's working. not hopes. Hope is a relevant dimension of life. Of course it is. We wouldn't live without hope. But one thing is hope, something else is an intervention that works, that does work. Another thing is an intervention that we hope it might work. There's very few of the first, there's many, many, many of the second. And we should be very clear with patients if we offer them something that works or we hope that might work.
Thank you, Giovanni. And I think the challenge sometimes is in the protocols that when you add especially some medical compounds or supplements, if there is no evidence, so there may be even the harm. So it's always what is the risk-benefit ratio. So there we need to be careful with the clinicians, what is the thing. Thank you so much. I know we are running out of the time, but I would love to have just a short concluding remark from all the panelists, just 1 or 2 sentences. What is the most important thing for the audience, for all of us, to take home, to really start implementing these results, what is available? Gill, please start.
I think the most important thing is there is hope, that it's not just heart disease and healthy lifestyle. There are many specific things. Education, we now know that keeping cognitively active throughout life, and more importantly and less intuitively, hearing and ensuring social contact. So we have a huge package to make a difference. We've already done some health economic in Lancet Public Health, I think, showing that some interventions have, modelling them with LSE, and they should save a very large amount of money. So not even just cost effective, but they should save money. I think economically, socially, and scientifically, this is an incredibly exciting time, and all of the audience here could take part in really changing the future in the world.
Thank you. And Gustavo?
First, we are learning a lot all together. Second, it's doable. It's doable in any environment, in any country, in any region, whatsoever you can imagine. So we are learning and it's doable. I think that the 2 messages, at least for me.
Thank you. Kate?
I'm not sure how to respond. I think that my message would be that we really need to embed prevention strategies into healthcare education, healthcare professionals' education, because what happens, the diagnostic experience is, in the 14 years since I've been diagnosed, I've met 1 person who hasn't had their hope taken away at the time of diagnosis. So we need to offer patients more hope and also give them the choice about whether they want to trial a new dangerous drug with severe side effects or a holistic approach. So I think it's about choice for everybody, not just the scientific community.
Thanks. Sandrine?
So I will say that we are so lucky to are here at this moment, because all is just on the way to give some positive results. Because now, if we are looking broadly at the global level, we saw that the incidence of dementia is decreasing, not because we focus on prevention of Alzheimer's disease, because we still are doing some trials, but because maybe of the level of education of the people who is increasing, and maybe because we have a positive collateral effect of what was done in prevention on cardiovascular. So by doing prevention on cardiovascular area, we have some good results on dementia. So what can be the future if we really focus on dementia? I'm sure that we will have a huge decrease in number, and my message is never too late.
Perfect. Thanks. And Giovanni?
Yeah, well, my message is comes from spelling out a debate that's been creeping into the discussion, which is the debate between interventions at the population level, widespread to reduce inequalities, and interventions at the individual level in brain health services, future memory clinics. There's a huge debate because resources are limited. Where should we place our bets? Where should we place our money? And my answer is on both. we can reduce dementia, but dementia and dementia risk, but we will reduce it by using both interventions at the population level and at the individual level.
Thank you. Clearly, there is hope on the horizon, much we can do today, and joint actions are needed. We give an applause for our fantastic panel. Thank you so much for being there, and thanks again for ADI for the possibility that we can focus on risk reduction. Thanks.
How beauteous is mankind.